The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always.
Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. Early bird pricing ends April 4th, so don't wait. Register now at aaputah.org events. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're back this week with Dr. Kristi Kleinschmit from the Division of Pediatric Psychiatry at the University of Utah. Welcome back, Kristi.
Hi, Paul. Thanks for having me back.
We've been talking about OCD, and we talked a lot last week about diagnosis of OCD. In the meantime, have you developed any disclosures?
I have no disclosures, no financial conflicts of interest, nothing.
Okay. Let's forge ahead. So last week we talked about the diagnosis of obsessive-compulsive disorder. Once you've established the diagnosis, and as you mentioned at the end of the episode last week, it's important to try to make the diagnosis as soon as possible so that you can begin to intervene. Does the timing of diagnosis change the intervention?
I think only in how severe it's able to get before you start treatment, right? So the milder the OCD, the less dysfunction, the less entrenched it is in the family and the kid's life, the more just therapies probably will be more effective. But the more severe it gets, it just gets to be a lot more tough to treat.
Sure. What are the treatment goals of treatment of OCD?
Yeah. So goals really, again, are just about function. Like we really want to decrease the distress that the kids are having with this and allow them to get on with their lives. It's possible they will have some sort of OCD, for the rest of their life. I think we didn't quite talk about this, but it is a lifelong disorder. It can be, but if you get the tools to manage it so it doesn't interfere with your function, things go a lot more smoothly.
So it's mostly a matter of learning how to live with it and learning how to manage it. We don't expect complete remission.
Yeah, we don't typically. That said, if you do get treatment, about 40% of kids can actually remit with it. So, so 60% will have it for some point in their life, but gosh, 40% is a pretty good remission rate if you can get treatment going.
That's very significant. Yeah. So what are the best treatments?
Yeah, first and foremost, gold standard is cognitive behavioral therapy to address the symptoms of OCD. And this is very much looking at a lot of those cognitive distortions that come with these compulsions, right? And these obsessions that, like if you don't do this, then something bad is going to happen to this other person. And so talking through that, looking at the behaviors that the compulsions are driving you to do. And then the biggest piece of that is exposure and response prevention, right? So basically, your brain is telling you if you do not wash your hands for a full 3 minutes, you are going to get your entire family sick, or grandma's going to, pass away or whatever. And so basically it's like, okay, we are going to challenge that belief that your obsession has given you, and we're going to prevent you from washing your hands for that amount of time. And we're going to show that nothing bad comes from that.
Let me just back up a little bit. On the cognitive behavioral therapy, the goal that you're working for then is that you're helping somebody understand these perceptions that they're having. And how do you redirect that in a child?
Yeah. So a lot of it is just building some distress tolerance, to be honest, right? Like the anxiety that comes from these disorders. I'm going to lump this a little bit into anxiety because this is also, the treatment for anxiety. But But the distress that comes with it just feels so overwhelming. And if you can start and lay some foundation with just, let's do some deep breathing, let's do some positive self-talk, let's, do some other types, behavioral activation, other types of distress management skills, so we can show you that even though your anxiety feels like it is overwhelming and you're never going to get better, you actually can do some coping skills to help manage your anxiety. So that's like the very first stage, is really just like, this feels terrifying, right? And to try to address, not doing these obsessions or not doing these compulsions feels like, they do them, right? Because it feels so horrific to not follow through on them. And so you teach them first and foremost, just how do we deal with the stress that just thinking about doing this is going to cause you, right? And that's like the first step, is just stress management, anxiety management, coping skills. And then you start to look at this hierarchy of fears, basically. And it's really interesting. Once you start diving in there, there are so many more obsessive or compulsive thoughts than I think anybody is really aware of before you start asking those questions. And you help the kids, what's the scariest thing you could possibly do? It's like, oh, the scariest thing I could possibly do is use a public bathroom, right? And so it's like, okay, that's going to go up there. You have your distress thermometer, that's going to go up there at 100, right? Well, like, what's scary, but maybe not the most scary? It'd be like, okay, well, maybe we could leave the TV on a level 4 volume instead of a level 5 volume. That's not as scary to me, right? And so you really just help them determine what things make them the most scared. And little kids can even do that, right? Like, they know what things scare them. They, even if they can't put words to precisely what that compelling like fear is, they can still tell you like what actions are really hard to do.
It really seems to me like it's a great exercise in empathy to be able to listen to someone carefully enough to know that something that is not necessarily frightening to me is very frightening for someone else.
Yeah, it is. It is. And the trivialization of it, of like, well, that's silly, right? Because sometimes,
Right.
they're irrational. These things are irrational, right? And so just coming at them with rationality, that is sort of part of like what CBT does for like generalized anxiety and, like fearfulness, right? Like,
Right.
okay,
Right.
what's the actual likelihood that you're going to encounter a snake outside today or
Right.
whatever?
Right. Right.
But for OCD especially, like, that doesn't matter, right? Because it's so irrational to begin with, right? Like, if I don't do this, then my mom is going to die in a car accident, right? Like, that's not rationally connected. And so you can't just come at that with some sort of rationality. It really is, you have to like expose yourself to the possibility of this and then support them to see that the bad thing actually doesn't happen.
Fascinating. What's the role for medication in OCD?
Yeah, so kind of like our other disorders, right? Like meds, we would suggest to use for very moderate to severe OCD. Certainly, if you've started therapy and you just can't get anywhere. The gold standard study called the POTS study did demonstrate that combination therapy, which was sertraline and CBT, was far better than CBT alone or sertraline alone. And both of those were about similar and far better than placebo itself. And so medications do have a role. I certainly would suggest for severe OCD, you probably are going to need both, because the amount of anxiety that comes with might not, it's pretty anxiety provoking to do CBT and exposures. And so you
Yeah.
just may have to get some meds on board to help with that as well.
And it also seems very clear to me that as you make the diagnosis of OCD, that trying to develop a strategy that involves getting someone some therapy is really important.
Yeah, it really is. I think, if it's mild and you have like a really supportive family and a really savvy kid, we can talk, there are some like self-help books and such out there. I think, if parents understand what like exposure response prevention is, like maybe you could do it on their own, but no, I think therapy is the cornerstone of how you're going to beat OCD.
So you talked about use of SSRIs. What about kids who don't respond to SSRIs? Are there other medications that get used for OCD?
Yeah. So For SSRIs, right, I'd try one and then I'd try another if the first one doesn't work for whatever reason. And then for non-SSRIs, typically my next level will be something called clomipramine. It's an old tricyclic antidepressant that actually is FDA approved for use in kids for OCD and can be highly effective. It does have some side effects that sometimes kids don't really like nausea. You have to be worried it can cause some prolongation of QT, and so a baseline EKG is recommended for that. But it can be really effective, especially if you've tried your SSRIs and they haven't been effective.
When we talked to Jeremy Kendrick a couple of months ago about the systemized treatment of anxiety in adults, citalopram was the medication that was studied and then escalated from there. You mentioned that sertraline has been studied. Is there something particular about sertraline, or is this like a lot of other things that you choose an SSRI that you're comfortable with and escalate and move over from there?
Yeah, I don't think there's anything magical about sertraline necessarily. It is the one that they did the study in, right?
Uh,
And it also does have an FDA indication for OCD. And so if you want to be completely above board and use your FDA approved medication,
sure.
sertraline, plus it's liquid, right? So you can titrate
Right.
it to really low doses for those little kids. But there's been some positive studies with fluoxetine and fluvoxamine, which we really never use for depression and anxiety in kids, is actually pretty effective for OCD. And so this is the time where, the old name brand Luvox could be something that, you might consider for OCD when you probably aren't thinking of it for anything else.
Interesting. When you think about therapy for kids, I'm guessing that involving families in therapy is probably helpful as well.
Oh, it is imperative. There's no way you're going to get this treated if you don't have families in therapy. And that is sometimes the most difficult piece of this for two different reasons, right? I think, families are busy and and often when they present to treatment, they have done a lot of things to accommodate the distress of the kids, right? Like they
Yeah,
have changed their morning routine, right? They've
right.
just allowed this OCD to kind of, take control because it's been so highly distressing for everybody to try to fight it, right? Like these kids can throw tantrums or have really bad episode, fits, or that's not the word I'm looking for, but just it can be so painful to see them get
Yes.
prevented, right? So families then asking them to pull back and stop accommodating the OCD can be hard because typically you'll see some sort of increase in behaviors from the kids as you're going through this treatment. So just asking them to rechange their routines that they've built and to tolerate the distress of their kid can be really hard. B, like we talked about, OCD runs in families, right? And so if all of a sudden one of your exposures is going to be, hey, we're going to go we're going to go touch doorknobs and we're not going to wash our hands for a little while and let's see what happens, right?
Mhm.
If you have a mom or a dad who has pretty bad OCD, maybe they're functioning with it, but they might not be able to tolerate the exposures that you're
Sure.
asking the kids to be doing, right? But if you don't have the parents buy-in and if they are not helping support the kids do these exposures and doing homework, right? You can't just do 1 hour of treatment a week and get this taken care of, right? You're doing 1 hour to put together the exposures, to talk through your coping skills. And then the families have to go and do these exposures, on the other 6 days of the week that you're not in therapy. And they have to know which coping skills to encourage their kids to use. And they have to help them fill out their distress tracker and monitor what their anxiety level's doing.
I'm often reminded of the old saying that a parent can only be as happy as their least happy child. And as I'm seeing families, for instance, where a child has influenza, everyone feels very, very sad because the child is miserable. And in the event of a chronic disease like this, there often will be a lot of workaround, a lot of it's terrible to watch your child in distress. And I suspect that for a good therapist, there's a lot of work in disassembling some of the workarounds that people have put together.
Yeah, yeah. I mean, and sometimes you don't even see them all, right? Like it takes you weeks and weeks of getting to know a family before you realize, holy cow, this whole entire family won't eat this specific food because of this
Yeah,
fear of choking that this kid has
yeah,
also convinced the younger kids about, right? And so even though the younger kids might not have OCD themselves, they're avoiding the same things because they've seen their older sibling, react in such a strong way to whatever their OCD is driving.
just in closing, to talk about a couple of things. So, one of the real challenges for me in practice with psychiatric disorders is A, how do I find the right therapist? And B, how do I get access to a therapist?
Yeah, such a good question. And I mean, certainly for this specifically, like parents have to know, like this therapist has to say that they do CBT and they have to say that they do exposure response prevention for treatment. And the parents need to be saying involved, right? And so if you tell parents, you're like, if they're only seeing your kid, they're not doing the therapy that you need them to be doing, because if you're not talking to the therapist, if you're not getting homework from the therapist, then it's not working. In order to find a therapist, right? I mean, certainly families can call their insurance companies and try to ask through that. Some are more helpful than others. I always go to Psychology Today. That's still the website I use. And I just search by zip code and I put in OCD and I put in the age of the kid and I look and see who's accepting new patients. I feel like the people on there keep their profiles pretty up to date. I certainly can't say like quality or not, but I do think that, we have a lot of good therapists. And it is, as much as it's a very complex disorder, like to be able to do CBT and exposures, it's a pretty satisfying and sort of straightforward therapeutic approach. And so I think if people say they can do it, they probably can do it.
I forget about that from one exposure to the next. Psychology Today is a great resource, isn't it?
Yeah, just because, they're so motivated. The people on there are motivated to stay in business, right? And so they really do keep their profiles, I think, more up to date than if you go to the insurance companies, where you'll get this list of like, oh my gosh, like that person hasn't been practicing for 20 years. I mean, it's not quite that bad, but it's hard.
Yeah, and in what we recognize as a chronic condition, what should we be feeling about the approach to medication? Are we thinking that we use medication for a very long time, or is medication help facilitate the therapies, or how do we approach medication?
Yeah, that's a good question, Paul. And as I'm thinking now, right, our sort of standard for most of what we're treating is, treat to remission and then treat another 3 to 6 months and then try to get off of medication. I think that's still a fair kind of rule of thumb for OCD treatment as well. You might find that though, if you try to pull the med back, their symptoms come back and then maybe they just have to be on for longer.
All right. Anything else we ought to be thinking about with therapy?
Just if kids are not responding, right, it's possible that it's severe enough that one time a week is just not enough. And so if that's the case, then I would go looking for like an intensive outpatient program or a day treatment program, just as your next escalation.
I've had some patients that has just been such an incredible boon in their life.
Yeah, because it really is more a type of like, almost like flooding, right? Okay, we're not just going to do once a week exposures. We're going to, you have to come every single day, and every single day at treatment, you're going to have a therapist assisted, like working through some of this. And then occasionally, right, I think we talked about like not responders to SSRIs. Like sometimes the distress of the exposures, even with an SSRI on board, is just too high. And so in that case, occasionally we might consider doing something like hydroxyzine or something, even like a low dose benzodiazepine, to just like take the edge off initially, right, while you're trying to do some of these exposures.
Excellent. All right. Well, thanks for your insights and your wisdom. For those of you who have questions, and I know you do, please send your questions to questions@vcurb.com, and we'll address those in a couple of weeks. Dr. Kleinschmit, thanks for your time and your expertise. I hope you're willing to come back next week, and we're going to talk about some of the more wide-ranging things that we may do for OCD.
Sounds great. Thanks, Paul.
All right. See you then.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, The content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.